Now, the way this pandemic has changed our lives can severely impact our mental health. And as 41 Action News reporter Jordan Betts shows us, medical experts are seeing the detrimental effects.
Child and adolescent mental health disorders are the most common illnesses that children will experience under the age of 18.
That's 15 million kids, most of whom don't get help.
We've seen an increase in not only the suicide hotline numbers, but the attempts have been more serious.
Experts say suicide is a growing concern during the pandemic. Data showing the volume of calls on the rise and the types of calls even more alarming.
Right now, a disturbing trend is emerging in 2020, a rise in suicide rates. Health officials are sounding the alarm, asking everyone to keep an eye on their loved ones and seek help if needed.
Hi, I'm Tom Brady, Director of the Homeland Security Training Institute, or HSTI, at College of DuPage. Welcome to the HSTI Community Workshop on Mental Health Basics and Suicide Prevention. This workshop is brought to you by College of DuPage, HSTI, and made possible by College of DuPage Multimedia Services. HSTI has partnered with the DuPage County Coroner, Dr. Richard Jorgensen, DuPage County Health Department's Behavioral Health Emergency Services Supervisor, Betsy Bosch, and Dr. Sylvia Donatelli, mental health counselor and professor at College of DuPage. Watching this workshop, you'll receive basic information about common mental health disorders and how they impact overall daily quality of life functioning. Participants will learn about the signs and symptoms associated with various types of mental health disorders and how to respond when individuals may need help. Viewers will also be taught how to distinguish mental health crisis situations and identify suicide risk behaviors, which may constitute a medical emergency. Resources about mental health treatment options and available therapies will also be provided along with links and phone numbers on our website. We are hoping this workshop will provide useful resources to help someone who is struggling with mental illness. Our first presenter today is DuPage County Coroner Dr. Richard Jorgensen, a retired surgeon who practiced at Central DuPage Hospital in Winfield and has made the most of his nearly 8 years as coroner. He has supervised the investigation of over 42,000 deaths in the last 8 years. He is a licensed physician and skilled trauma and vascular surgeon that brings a wealth of medical knowledge to the office. Now let's hear from Dr. Richard Jorgensen.
Tom, thank you for that very kind introduction. Again, my name is Richard Jorgensen. I'm the DuPage County Coroner. We deal with all of the deaths in DuPage County, especially deaths due to unnatural causes such as suicide, and that is the topic of our discussion today. Do we have a problem? This slide shows from 1999 to 2015 the causes of death in America. And as you can see that drug overdoses have far outstripped every other cause of death. But you can see that the second most likely cause of a death is suicide. It has gone over motor vehicle accidents, firearms, and homicides, all other causes of unnatural deaths. And as you can see, each year it continues to rise, and this continues to be the case in the last year. In DuPage County, suicide deaths were up again last year, and we're probably going to have about 105 suicidal deaths in a county of 925,000 people. I looked at this data very carefully because, as we all know, 2020 was a very unusual year. And I analyzed the deaths starting at the 6-month period of time, and I'm going to finish up by showing you the full year statistics. But it was very alarming that at 6 months, it was about halfway through the pre-COVID era and the COVID era. And just to remind you that the governor shut down the state on March 16th. And so you can see that at about the 6-month period of time, we had 44 deaths in 2019, and we had 54 deaths in 2020. That is a 22.7% increase in the number of suicidal deaths in DuPage County, which obviously is a very large number. The pre-COVID lockdown, or the pre-COVID time represents 76 days, which is about 42% of that 6 months. And the post-COVID lockdown is 105 days, which is about 58% of the time. But 37% of the deaths were in the pre-COVID time, and 67% of the deaths were in the COVID lockdown time. It is obvious that the stress of being in a pandemic, in a time when you cannot socially communicate and be with people, has affected the suicide rate in DuPage County. Looking at ethnicity, it very much mirrors the ethnicity of DuPage County. The numbers on the left are the actual demographics of our county. The numbers on the right are the number of suicides in that ethnic group. Throughout America, it has always been that Caucasians and Asians, to a lesser degree, are more likely to commit suicide than African Americans and Hispanics. And this continues to be the same. I'd like to look at the demographics of this is for the whole year of 2020. It looks like we're going to have 105 deaths due to suicides. As you can see, males were 81 and females were 24. So it's about 80% males, and in DuPage County, it's mainly white males of all age ranges. The age range for the entire 2020 period was from 16 was our youngest, and 84 was our eldest. And in looking through the ranges, you can see that it is spread out throughout the decades of life. We had 5 people in their teens, 13 in their 20s, and then going on, 50 to 59 was the highest number of deaths, followed by 60 to 69. And we also had 5 people who were in their 80s that committed suicide. I analyzed every one of these deaths and tried to get as much information as I could regarding the risk factors. There's no question that the pandemic was a risk factor in that we had many people who had lost their jobs due to the pandemic, and we unfortunately had an elderly lady who committed suicide and basically had told her family over and over that she couldn't tolerate the fact that she couldn't see her family and couldn't be with anyone anymore. But in virtually every single one of these cases, one of these risk factors, and usually multiple risk factors, were present. History of mental illness, history of depression, personal problems, financial problems, marital problems, previous drug dependence or rehabilitation, and people who are divorced, never married, and or living alone. Very commonly, it would be someone who had financial problems, who was getting divorced, who was living alone in an apartment, and committed suicide. So these risk factors are very, very important to know in this time period while we're still in the pandemic. What can we do about this? The thing that has always been frustrating to me about suicides is that it's very common that people do have previous attempts or previous problems, but there are also people that it just comes out of the blue, and the family thinks that things are going well, and then a person commits suicide. But I've put these risk factors up here and tried to delineate these so that we can, as a community, reach out to our friends and families and neighbors that if we know that they have these risk factors, you can still visit somebody with a mask. You can still meet them on their porch. You can call them up. We can try to reach out to people that we know have these problems. So this is an introduction into the demographics, the risk factors, and the facts of what we've had happen in DuPage County over the last year. I truly hope that it changes over this new year, but we're still in the pandemic. So I still reach out to you and ask you to reach out to your neighbors and friends and see if we can make a difference in helping them. And I thank you very much for your time in allowing me to present this information. Thank you.
Thank you, Dr. Jorgensen, for your insight. Betsy Bosch is a Behavioral Health Emergency Services Supervisor at DuPage County Health Department. Betsy has over 10 years' experience in emergency services and is currently the Project Director for DuPage County Health Department's Suicide Prevention Follow-Up Program. She is also a certified instructor for Mental Health First Aid and Crisis Prevention Institute. Betsy is passionate about access to mental health care for vulnerable populations, especially those experiencing suicidal thoughts. Now let's hear from Betsy.
Thanks, Tom, for the introduction. I'm here to provide you with some information about mental illness, including the signs and symptoms of common mental disorders. We'll review mental health crisis situations and how to respond appropriately, including how to respond to individuals who may be expressing suicidal thoughts or behaviors. Later, we'll discuss different types of mental health services and where to access help and support in our community. Let's start by defining mental illness. What is it? Mental illness involves abnormal alterations in thinking, mood, or behavior. This causes distress and impaired functioning and can lead to difficulty in social, personal, and occupational situations. It can also lead to premature death. In the U.S., the average life expectancy is 77.9 years. However, for those with a major mental illness, it is anywhere from 49 to 60 years. According to the World Health Organization, about 1 in 4 adults has a diagnosable mental disorder, and the Surgeon General reports that mental illness is more common than cancer, diabetes, or heart disease. 2015 data for the state of Illinois indicates that 1,029,580 people experienced severe psychological distress. According to the National Institute of Mental Health, 4 of the 10 leading causes of disability are mental disorders in the U.S. and other developed countries. However, despite its prevalence, it's important to note that more than 2/3 of Americans who have a mental disorder lead productive lives within the community. Now let's review some common myths related to mental illness. The first one, all people with mental health problems are violent and unpredictable. This is false. The truth is that most people with mental illness are not violent. Only 3 to 5% of violent acts are attributable to individuals with serious mental illness. In fact, people with serious mental illness are 10 times more likely to become victims of violent crime themselves. Some of the risk factors for being a target of violence are co-occurring disorders and psychosis, which can include command hallucinations and delusions. We'll talk about these and other symptoms of psychosis later. Another myth about mental illness is that personality flaws or character deficits are the cause of mental health problems, and that people with mental disorders can just snap out of it. This is also false. Mental health problems are caused by a variety of factors, including biological factors like genes, physical illness, injury, and brain chemistry, life experiences like trauma and abuse, and a family history of mental problems. One final myth is that individuals can't do anything to support someone with a mental health problem. Again, this is false. It's important to acknowledge that individuals with mental disorders can get better and do recover completely. Recovery is the process in which people are able to live, work, learn, and participate fully in their community. Friends, family, and community members can support recovery by encouraging services, not contributing to stigmas about mental illness, treating individuals with respect, being informed about mental illness, and helping individuals to access services. There are over 20 categories of mental health diagnoses, but for the purposes of this presentation, we'll only be reviewing some of the most common mental disorders. We'll start with a review of anxiety disorders. Anxiety is a normal part of life, but disorders are more than just temporary anxiety. The symptoms of an anxiety disorder are more severe and cause impairment in daily functioning. Anxiety disorders commonly co-occur with other mental illnesses, like depression and substance use disorders. Generalized anxiety disorder, or GAD, is one type of anxiety disorder. It can be characterized by feelings of restlessness or feeling wound up, being easily fatigued, difficulty with concentration or having the mind go blank, irritability, muscle tension, difficulty controlling worry, and problems with sleep, including difficulty falling or staying asleep and restless or unsatisfying sleep. Another common anxiety disorder is panic disorder. Symptoms of panic disorder include sudden and repeated attacks of intense fear, a feeling of being out of control during a panic attack, intense worry about when the next attack will occur, and fear or avoidance of places where panic attacks have occurred in the past. While obsessive-compulsive disorder is now in its own class of disorders, it does have symptoms similar to that of anxiety disorders, so we'll review it here. Obsessive-compulsive disorder can be very debilitating. We all double-check things from time to time, but for someone with OCD, they can't control their thoughts or behaviors, and they spend so much time attending to these that it causes disturbances in daily functioning. There are two key components to OCD. Obsessions, which are repeated thoughts, urges, or mental images that cause anxiety. Some examples of obsessions are fear of germs or contamination, unwanted or taboo thoughts, sometimes involving sex, religion, and harm, aggressive thoughts towards self or others, or the need to have things in symmetrical or perfect order. Then there are compulsions, which are repetitive behaviors in response to an obsessive thought. Some examples of compulsions are counting, excessive cleaning or hand washing, ordering or arranging things in a precise way, and repeatedly checking on things, like if a door is locked or checking to see if an oven is on. As mentioned earlier, symptoms of anxiety, panic, and obsessive-compulsive disorder are severe and interfere with daily activities and social or professional relationships. We'll discuss how to respond to someone experiencing extreme anxiety a little later. Now we're going to move on to another category of mental disorders, trauma and stress-related disorders. These types of disorders can arise from experiencing, witnessing, or being confronted with one or more traumatic events. A traumatic event is any incident experienced or witnessed by a person that is perceived to be traumatic. Trauma is a subjective experience. Individuals who have experienced the same trauma may have very different responses. What is perceived by one person as traumatic may not be to someone else. Traumatic events can include things like accidents, like traffic accidents, physical accidents, fires, or severe injury, abuse, like physical, sexual, or emotional abuse, mass trauma, like natural disasters, terrorist attacks, or mass shootings, or community violence. These disorders cause distress, anxiety, and some trauma-specific symptoms we'll discuss in more detail. We'll start by reviewing acute stress disorder, and then we'll discuss post-traumatic stress disorder, and we'll cover the symptoms associated with both of these. Let's review acute stress disorder. So what is it? Anyone can develop acute stress disorder after a traumatic event. Symptoms usually last at least 3 days, but end after 1 month. Symptoms include dissociation, re-experiencing, avoidance, anxiety or increased arousal, and distress. Let's review some information on each of these symptoms in more detail. Dissociation can involve feeling numb, detached, or emotionally unresponsive. It can also involve dissociative amnesia, which is when you cannot remember things about the traumatic event. Re-experiencing is having recurrent thoughts, images, flashbacks, and/or nightmares about the traumatic event. Some individuals may also feel like they're reliving the event or feel a sense of distress when reminded of the trauma. Avoidance is when individuals avoid any triggers that cause them to remember or re-experience the traumatic event. This can include people, places, objects, activities, thoughts, or feelings that trigger their trauma. Anxiety or increased arousal includes having trouble sleeping, being irritable, difficulty concentrating, being unable to sit still, being constantly tense or on guard, or being startled easily or at inappropriate times. Symptoms of acute stress disorder can also cause distress or disrupt areas of someone's life, like work or social functioning. It may interfere with completion of daily tasks or an inability to open up to others about the event. Keep in mind that with acute stress disorder, these symptoms are only present for up to 1 month. If symptoms persist longer than 1 month, it's likely progressed to post-traumatic stress disorder. So what is post-traumatic stress disorder, or PTSD? PTSD, like acute stress disorder, is a disorder that develops in some individuals after experiencing, witnessing, or being exposed to a traumatic event. It causes individuals to feel fear and stress after the event is over. Exposure can be direct or indirect. Repeated exposure to details of someone else's trauma can also cause PTSD symptoms. An example of this was the PTSD that some experienced after seeing repeated images of the planes flying into the World Trade Center on 9/11 and the aftermath of that attack. These repeated exposures caused PTSD for those that didn't necessarily experience the event firsthand. Complex trauma is when an individual is exposed to multiple traumatic events. These are often severe and pervasive, like abuse or profound neglect. So who does PTSD affect? About 3.5% of the general population are diagnosed with PTSD. However, about 60% of men and 50% of women will experience a traumatic event at least once in their lifetime. Based on these statistics, it's clear that not everyone who experiences a traumatic event will develop PTSD. PTSD often co-occurs with substance abuse. 22 to 43% of people diagnosed with PTSD also have a co-occurring substance use disorder. One Harvard study reports that 2/3 of people in residential substance abuse treatment report a traumatic experience. Many of the symptoms of PTSD are similar to those reviewed with acute stress disorder. Individuals may experience reoccurring and distressing memories of the event, distorted thoughts about the event, flashbacks or nightmares, sleep disturbances, reckless behavior, hypervigilance, detachment, feeling numb or emotionally unresponsive, difficulty concentrating, avoidance of triggers, negative beliefs, diminished interest in activities, a persistent negative emotional state, anger outbursts, and an exaggerated startle response. Later, we'll discuss ways you can support someone after a traumatic event. Next, we are going to review another category of mood disorders, depressive disorders. Depression is one of the most common mental disorders in the U.S. 16 million individuals, or 6.9% of the population, had at least one depressive episode in the last year. Depression can happen at any age, but it often begins in adulthood. Depression can co-occur with other serious medical illness, especially in midlife or with older adults, like diabetes, cancer, heart disease, and Parkinson's disease. Oftentimes, these conditions are worse when depression is present. Major life changes, trauma, or stress can precipitate a depressive episode. Major depressive disorder is one of the most common types of depressive disorders. It lasts for at least 2 weeks and causes impairment in daily functioning. Major depressive disorder not only affects a person's thoughts, feelings, and behaviors, but can also impact their relationships and ability to carry out daily activities. The severity of symptoms, duration of symptoms, and impact on a person's life are what distinguish between feeling depressed and having an actual depressive disorder. The common feature of all depressive disorders includes sadness, emptiness, or irritable mood. Other symptoms can include issues with sleep, either sleeping too much or sleeping too little, withdrawal and isolation from others, weight loss or weight gain, neglecting responsibilities, lack of interest or motivation, feelings of hopelessness or helplessness, guilt, anger and mood swings, impaired memory and concentration, and self-blame. Depressive disorders can also feature thoughts of death or suicide. We'll discuss how to respond to someone experiencing suicidal thoughts or behaviors later in this presentation. Other types of depressive disorders include persistent depressive disorder, or dysthymia, postpartum depression, and substance-induced depressive disorder. Next, we're going to review some basic information about bipolar disorder. Bipolar disorder, which was previously called manic depressive disorder, causes shifts in a person's mood, energy, and ability to function. It is characterized by cycling between episodes of mania and depression. This is more than just feeling the normal ups and downs of life. The symptoms of bipolar disorder are severe and can be very debilitating. Let's talk about these high and low symptoms of bipolar disorder in more detail. The lows of bipolar disorder are depressive symptoms, those we reviewed previously. This can include feelings of sadness, emptiness, or irritability. The high of bipolar disorder is referred to as mania. This is a sustained, abnormally elevated mood with intense energy, racing thoughts, and other extreme behaviors that cause impairment. Hypomania is similar, but less severe. It's an elevated mood and energy state that is abnormal, but not so extreme that it causes disruption or impairment. Symptoms of mania last at least 1 week and are present most of the day, nearly every day. Here are some examples of the depressive and manic symptoms associated with bipolar disorder. Depressive symptoms of bipolar disorder include loss of pleasure in usual activities, lack of energy and motivation, trouble concentrating or making decisions, restlessness and irritability, feelings of worthlessness, self-hate, or guilt, changes in eating, sleeping, or other habits, and thoughts of death or suicide. Some of the manic symptoms of bipolar disorder include inflated self-esteem or grandiosity, decreased need for sleep, being talkative or rapid speech, racing thoughts, distractibility, an increase in goal-directed activity. Typically, this is related to work and social activities, and impulsivity and high-risk behaviors. These can involve spending sprees, sexual promiscuity, gambling, or other undesirable or unsafe behaviors. Again, it's important to note that the symptoms of bipolar disorder are more than just the ups and downs of life. The symptoms are severe and cause functional impairment and disruption to everyday activities. Next, we'll review schizophrenia and other disorders of psychosis. Schizophrenia is a chronic and severe disorder that affects how a person thinks, feels, and acts. Although schizophrenia is not as common as some of the other mental disorders we've discussed, the symptoms can be very disabling. Only about 8 of every 1,000 individuals will have schizophrenia in their lifetime. 75% of people who have schizophrenia experience their first episode between the ages of 16 and 30. It is rare to develop schizophrenia after the age of 45. Some individuals with psychosis may lack insight or awareness of their disorder. This is a symptom of schizophrenia itself, rather than a coping mechanism, and is also a common predictor of treatment noncompliance. Positive symptoms of schizophrenia and other psychotic disorders are behaviors that are not generally seen in healthy people. People with positive symptoms may have lost touch with some aspects of reality. For some individuals, these symptoms may come and go, and for others, they remain stable over time. Some examples of positive symptoms are delusions, hallucinations, disorganized thinking, and abnormal motor behavior. Let's talk about some of these positive symptoms in more detail. Delusions are fixed beliefs that are not amenable to change, despite conflicting evidence. The content of delusional thoughts can include a variety of themes. Persecutory delusions involve a belief that an individual is at risk of harm. With grandiose delusions, an individual believes that they have exceptional abilities, wealth, or fame. Hallucinations are sensory experiences that occur in the absence of a stimulus. They are vivid and clear and experienced just as normal perceptions, but they are not voluntary in nature. They can occur in any sensory modality, but auditory and visual hallucinations are the most common in schizophrenia and other psychotic disorders. Disorganized thinking involves unusual or dysfunctional ways of thinking. And since we never really know what's going on in someone else's head, this is inferred from an individual's speech. The individual may switch topics frequently or discuss unrelated topics, which is referred to as tangential speech. Their thoughts may also be so disorganized that it is nearly incomprehensible, which is sometimes described as word salad when discussing symptoms of psychosis. Abnormal motor behavior can manifest in a variety of ways, anything from uncharacteristic or silly behavior to unpredictable agitation. Some of these behaviors may repeat over and over. Catatonic behavior is a decrease in reactivity and can also be associated with schizophrenia and other disorders of psychosis. Negative symptoms are associated with disruptions to normal emotions and behaviors. These negative symptoms impact an individual's ability to complete everyday tasks, such as personal hygiene, grooming, and other activities of daily living. Negative symptoms are common in schizophrenia, but are less prominent in other psychotic disorders. Let's review some of these negative symptoms in more detail. Diminished emotional expression is just that. It includes reductions in emotional expressions in the face, eye contact, intonation of speech, and the movements of the hand, head, and face that give emphasis to speech. Avolition is a decrease in motivated, self-initiated, and purposeful activities. The individual may sit for long periods of time or show little interest in participating in work or social activities. This may also cause impairment in an individual's ability to keep up with activities of daily living, like showering or preparing meals. Anhedonia is the decreased ability to experience pleasure from positive stimuli. People with anhedonia no longer enjoy the things that they once loved. Asociality is another negative symptom and refers to the lack of interest in social interactions. Individuals with asociality either limit social interactions or cut off all social interactions completely. There are also several cognitive symptoms of schizophrenia and other disorders of psychosis, which have a profound impact on these individuals' ability to work and carry out social relationships. There are changes in memory and other aspects of thinking that make recalling and accessing stored information difficult. There's also poor executive functioning, which impacts the ability to understand information and make decisions. In addition, there can be trouble with focus and attention, making conversations and social situations challenging. And problems with working memory, which allows people to effectively use information immediately after learning it. Individuals with schizophrenia and other disorders of psychosis may struggle with working memory. Although schizophrenia and other disorders of psychosis are not as common as other mental illnesses we've discussed, it's important for you to be aware of these symptoms, as you may encounter someone experiencing psychosis at some point in your lifetime. Later, we'll discuss crisis situations involving severe psychosis and how to respond. Next, we're going to review some basic information about substance use disorders. Substance use disorders are real illnesses, just like other mental disorders we've reviewed today, and have a variety of impacts across the lifespan. Oftentimes, substance use disorders co-occur with other mental health problems. Alcohol and other substance use also increases risk for suicide. While alcohol is the most commonly used substance, any substance, legal or not, can be misused. There are also behaviors like gambling, sex, exercise, or shopping, which have the same chemical impact as substance use and can be extremely addictive, even though not recognized as separate mental disorders yet. All drugs taken in excess directly activate the brain's reward system, which reinforces behaviors and the production of memories. Instead of activating these reward systems through adaptive behaviors, substance use can act as a shortcut for achieving the same feelings. Substance use disorders frequently co-occur with depressive, anxiety, and psychotic disorders, and are often referred to as dual diagnoses. Oftentimes, alcohol and other substances are used as a way to self-medicate or manage the symptoms of another mental disorder. The use of alcohol or other drugs on its own does not mean that a person has a substance use disorder. In order for substance use to be qualified as a disorder, there need to be psychological, behavioral, and cognitive symptoms indicating an individual's continued use despite significant problems related to their substance use. Some warning signs that substance use may be problematic for an individual are the need to use the substance in larger quantities or over extended periods of time. The need to use larger amounts of a substance to achieve the same high is called tolerance. An individual's persistent expressed desire to cut down or regulate use is also indicative of a substance use problem. The individual might also report unsuccessful attempts to reduce or abstain from use. The individual may also spend a great deal of time either obtaining the substance, using the substance, or recovering from use of the substance. An individual may give up important activities like work, social, or family activities to spend more time using their substance of choice. When all of an individual's activities revolve around substance use, it can indicate a severe substance use disorder. Cravings or intense urges to use the substance, preoccupation with the substance, and symptoms of withdrawal may be another signal of problematic use. Risky use of the substance may include use in situations where it's physically hazardous to the individual, as well as persistent physical and psychological problems that are exacerbated by substance use. Either of these things can be a sign of problematic use. In a moment, we'll discuss ways to assist individuals in seeking substance use treatment, particularly those in need of immediate intervention. Now that we've reviewed some of the signs and symptoms of common mental disorders, we're going to discuss ways to assist individuals who may be in need of mental health support. We'll talk through different types of mental health crisis situations, how to respond, and how to get these individuals connected to professionals within our community. So what constitutes a mental health crisis? As you have probably learned by now, the answer is different for everybody. So we'll define a mental health crisis as feelings of intense fear or distress that overwhelm an individual's ability to utilize natural supports or coping mechanisms to achieve a regulated state. Crisis situations can be mental, emotional, or physical. During crisis situations, it's important that we keep everyone safe, that we don't make the situation worse, and that we connect the individual to appropriate supports. We're now going to discuss each of these steps in more detail and review how to respond to different mental health crises. The way you respond to a crisis situation will have a profound impact on the outcome of the intervention. We want to do our best not to escalate the situation, trigger the individual, or cause trauma. So by responding appropriately, we can minimize the risk of further harm. When interacting with an individual in crisis, it's important to be mindful of your reaction to the situation. Here are some things to be aware of. Consider your position in relation to the person. Are you too far away from the individual? Too close? You want to be close enough to be engaged and supportive, but not so close that you're compromising your own safety or the comfort of the individual in crisis. You also want to be mindful of your stance and posture. Are you conveying a sense of openness? Are you able to exit the area if you need to? You also want to consider your verbal and nonverbal responses. Again, are you conveying support and willingness to help? Think about your tone, facial expressions, and gestures, and how those might be interpreted by the person in crisis. It's important to remain calm and confident in your response. You also want to be aware of the environment or your surroundings. Are there any immediate safety concerns? If the individual is expressing intent to harm themselves or someone else, is there anything around that they could use to do this? Are there any bystanders? And if there are, should they be escorted away from the situation or asked to assist in some way? Be sure to use positive communication. We want to be respectful and supportive without tolerating any dangerous or inappropriate behavior. State your intentions to help the person. Do not try and challenge any of their thoughts or beliefs about the crisis. We also want to focus on being safe for now. This is a phrase we use often in crisis settings to ensure someone's immediate needs and safety concerns are addressed. You'll probably want to help the person access professional help. But is that something that needs to happen right now? Is there someone you can call together? We'll review some resources for support a little later in this presentation. Now we're going to review some different types of crisis situations. Some of the situations we'll cover may present no urgent safety concerns, and therefore won't warrant seeking additional help right away. However, some of these situations do involve medical or psychiatric emergencies, and urgent professional assistance may be necessary. Let's talk through each of these situations one by one. Panic attacks are characterized by a sudden and extreme increase in anxiety, and can be fairly common for individuals with an anxiety disorder. Many people have or will experience a panic attack during their lifetime, but few go on to develop an anxiety or a panic disorder. It's not always easy to tell if a person is having a panic attack, and the symptoms can appear similar to a heart attack, so it's very wise to be cautious in these situations. During a panic attack, an individual may experience the following symptoms: shortness of breath, trembling or shaking, rapid heart rate, sweating, chest pain or discomfort, nausea, chills or hot flashes, or dizziness and feeling faint. Panic attacks usually come on suddenly and have their peak within about 10 to 15 minutes. If you encounter an individual who may be experiencing a panic attack, it's important to express concern and your willingness to help. It's also important to ask the individual if they know whether or not they're experiencing a panic attack. Oftentimes, individuals who have experienced one before will know what's happening. If they don't know or have never experienced a panic attack before, seek immediate medical assistance and remain with the person until help arrives. If the person believes they're having a panic attack, ask if you can help and provide support in the following ways: remain calm, speak slowly and clearly to the individual, be patient, acknowledge the fear and terror that they are experiencing as a result of the panic attack, provide reassurance that it's a panic attack and not life-threatening, and avoid any negative reactions. This will only escalate the situation further. Another type of crisis situation you may find yourself in is how to support someone following a traumatic event. Remember, a traumatic event is any incident experienced or witnessed by a person that is perceived to be traumatic. Immediately following a traumatic event, you want to determine if the person is currently safe, and consider your own safety in responding to the situation. Check for any potential dangers and call for help if the situation is not safe. If safe to do so, address the individual's basic needs. This can include attending to any injuries or providing things like food, clothing, shelter, and water. You may want to offer the person choices, which will help them regain a sense of control. Do not pressure the person to share their story or open up about the incident. Likely it is too soon to process what has happened. However, you do want to encourage the individual to tell others what they need, and when the time is right, consider appropriate professional help for ongoing support if needed. Remember to also respect the person's privacy, unless the situation is unsafe and you need to request emergency assistance. Another situation which may become a crisis may involve someone with non-suicidal self-injury. What exactly is non-suicidal self-injury? It is intentional, self-inflicted damage to body tissue without the intent to die by suicide. Individuals may harm themselves in a variety of ways. Cutting, burning, headbanging, picking skin, and pulling out hair are common forms of non-suicidal self-injury. Self-injury is not categorized as a mental disorder by itself, but is usually a symptom of mental illness or psychological distress. So why do people do it? Well, there can be lots of reasons for that. Sometimes it's a way to express something that is hard to put into words. It can also make thoughts, feelings, or experiences visible for someone. It can also change emotional pain into physical pain. And it can give someone a sense of self-control when things are feeling out of control. So how do you respond? Do not ignore it. If you suspect someone is engaging in non-suicidal self-injury, you need to discuss it with them. Start by letting them know that you've noticed the injury or injuries and that you're concerned. Encourage the person to speak to someone they trust the next time they feel the urge to self-injure. Discuss ways to manage their distress without self-injuring. You can also assist them in finding appropriate professional supports if needed. If an individual is in need of medical attention due to the severity of their injuries, you should call for help. Another crisis situation might be an individual experiencing severe psychosis who could be at risk of harming themselves or someone else due to their symptoms. In these situations, you should attempt to de-escalate the situation. Remain calm and use simple sentences. Speak softly and in a non-threatening voice. Do not challenge what they're saying. Try to focus on how the person feels versus what they're hearing or what they believe. If the individual is able to identify someone they trust, it can be a good idea to enlist their help. If your safety, the safety of the individual, or the safety of others is compromised, get help immediately. If requesting help from 911, it may be possible to send a police social worker or an officer with CIT training. This is an in-depth crisis intervention training that is provided to law enforcement to educate on mental health disorders and crisis situations. In the event you find yourself with an individual with a substance use issue who is ready to get help or in need of medical attention, there are some things to keep in mind. Let's start with a substance use crisis situation, one that would warrant immediate medical attention. An overdose involves having more of a particular substance or a combination of substances that your body can't handle. An overdose, whether intentional or not, is always a very serious situation and requires immediate medical attention. In these instances, call 911 right away. While you wait for help to arrive, put the individual in the recovery position, which is shown here. If they have any injuries to the head, neck, or back, do not use the recovery position and leave them as they are instead. If you suspect that the individual has overdosed on opioids, such as heroin or prescription pain medication, and you have access to naloxone, you can administer it to potentially save the person's life. Narcan, or naloxone, which is the brand name for Narcan, is widely available and is a safe and effective antidote that works by temporarily blocking opioid receptors. If you would like more information about Narcan, including how to access Narcan for yourself or a loved one, you can find it through the DuPage Narcan program. There are a few other substance use-related situations that may pose urgent medical or safety risks. You should seek help if you encounter an individual experiencing alcohol poisoning, severe withdrawal symptoms, aggressive behaviors, or any suicidal thoughts or behaviors. We'll talk about how to respond to suicidal behaviors in just a few minutes, but it's important to note that substance use increases an individual's risk for suicide. So these are situations where it's important to seek professional help. And what about situations that may not be a crisis or pose an immediate threat, but an individual with a substance use problem is ready to get help? Well, it's important to respond in a way that supports their recovery. You want to be respectful. Listen without judgment to their call for help. Do not lecture or provide your opinions about their substance use during these conversations. Be aware that willpower and motivation for change may not be enough. Many individuals need additional supports to decrease substance use. Abstinence is not always the goal. Reducing the amount used or frequency of use can lead to improved well-being. Harm reduction strives to reduce negative consequences associated with use, and there are many effective harm reduction programs out there. Help the person to identify local professional supports. These professionals can identify the appropriate course of treatment to address their substance use. Research information on local self-help groups. Alcoholics Anonymous and Narcotics Anonymous offer free, peer-led meetings in most communities on a daily basis. As we finish our review of mental health crisis situations, I want to spend some time discussing an important topic: suicide and suicide prevention. Suicide is the 10th leading cause of death in the United States and the 11th leading cause of death in Illinois. White, middle-aged men have the highest risk for suicide, but women and teenagers make more attempts. This is because men typically use more lethal means than women and teens. Since Dr. Jorgensen already reviewed some statistical information about suicides in our community, I'm going to focus on some other areas of suicide prevention, like warning signs, risk factors, and how to determine risk. We'll start by reviewing some myths about suicidal thoughts and behaviors. One of the most common myths about suicide is that talking about it or asking about it is going to put the idea in someone's head. This is false. Often, asking about suicide offers the person an opportunity to talk about their distress and acts as a deterrent to suicide. It can also be a good opportunity to link individuals to help. Another myth is that suicide happens without warning. Again, false. Instead, there are often warning signs of suicidal intentions. We'll cover some of these in more detail in a moment, and familiarizing yourself with these warning signs could help you to save a life. The next one, once suicidal, an individual will always be suicidal. Again, false. Suicidal ideation is often brief and situation specific. An individual with suicidal thoughts or previous suicide attempt may never be suicidal again in the future. Some claim that people who take their lives are selfish and looking for an easy way out. This is simply not true. Individuals who experience thoughts of suicide typically want to end their suffering. This is not a choice and not a selfish decision. It is the result of very serious mental distress or a difficult life situation. And finally, suicide only impacts certain races and socioeconomic groups. Wrong again. Suicide occurs across all races and socioeconomic classes. Now, let's review some of the warning signs for suicide. Warning signs are things to look out for when you're concerned about someone or suspect that they may be suicidal. Most people who die by suicide display one or more warning signs, either through what they say or how they behave. Some potential warning signs are seen here. There can be warning signs via communication, like threats to harm or kill oneself, writing or posting about death, feeling hopeless, having no reason to live, feeling burdensome or trapped, or feeling unbearable pain. There can also be behavioral warning signs, like increased drug and alcohol use, seeking access to a means to kill oneself, withdrawing from activities, isolating, sleep disturbances, reckless behavior, giving away possessions, or aggression. Changes in mood can also be warning signs of suicide, like lack of interest, irritability, shame, anger, emotional dysregulation, low sense of belonging, depression, and anxiety. You should also be concerned if you notice a sudden improvement in someone's symptoms. Sometimes this can be an indicator that they're at peace with the idea of suicide and that they have already made plans to end their life. It is important to note that there is no single cause for suicide, and not everyone who is depressed is at risk for suicide, and not everyone who is at risk for suicide is necessarily depressed. Risk factors are characteristics or conditions that increase an individual's likelihood to attempt or die by suicide. Some common risk factors are listed here. The difference between risk factors and warning signs is that warning signs are messages, behaviors, or feelings a person may display, indicating that they are suicidal. Risk factors are characteristics that put them at increased risk, some of which they may have no control over. You'll notice that there are health, environmental, and historical factors listed that can increase someone's risk for suicide. Some health factors include a diagnosed mental condition, serious physical conditions, brain injury, and substance use disorders. Suicidal thoughts or behaviors can also result from side effects of medication or changes in hormone levels. Environmental risk factors include access to lethal means, prolonged stress or stressful life events, or exposure to suicide. Historical factors are things like previous suicide attempts, a family history of suicide or mental health conditions, or childhood trauma. Additionally, a period of heightened risk exists following discharge from inpatient psychiatric hospitalization. Estimates show that as many as 20% of all suicides involve alcohol use. The single greatest risk factor is a history of attempts. 30 to 40% of people who die by suicide have made a previous attempt. The risk is also 100 times greater in the first year following an attempt. So how do you determine if a person is at risk? Asking directly about a person's suicidal thoughts or behaviors is the only way to be sure whether or not the person has definite intentions to end their life. Ask, are you having thoughts of suicide? Or, are you thinking about killing yourself? If the answers to either of these questions are yes, additional information needs to be gathered to fully assess risk. A higher level of planning indicates a greater risk. Be careful not to say things like, are you thinking of harming yourself? Because the answer to that question may not provide the information you need to know. Lack of buffers or protective factors may also indicate greater risk. Buffers and protective factors include things like reasons for living, supports that are immediately available, a sense of purpose, planning for the future, and core beliefs. Keep in mind that the absence of a plan does not necessarily ensure a person's safety. And take all threats of suicide seriously. So where can you or someone in need get help? The National Suicide Prevention Lifeline is a 24/7 nationwide hotline. Individuals can call for support for their own suicidal thoughts, or friends and loved ones can contact them to get guidance about how to support someone with suicidal ideation. You can also call the Suicide Prevention Lifeline for general mental health support. The number for the Lifeline is 800-273-8255. The Crisis Text Line is another form of 24/7 support. You can text crisis counselors by sending REACH to 741-741. Again, this service is for individuals struggling with suicidal thoughts themselves or people who may be supporting someone with suicidal ideation. More general mental health support is also available through the Crisis Text Line. Another resource in our community is the DuPage County Health Department. Within the Crisis Services Program at the Health Department, there are a variety of services available to address the urgent mental health needs of individuals in our community. The DuPage Crisis Line is staffed 24/7 by crisis counselors who can provide support and resources to those who are experiencing a mental health crisis or in need of more general mental health support. In-person crisis evaluation and crisis counseling is also available, either on-site at our center in Wheaton or in community-based settings like homes, schools, and healthcare settings. There is also a crisis residential program for individuals who may be in need of psychiatric stabilization but don't meet the threshold for inpatient hospitalization. Crisis Residential is a short-term, voluntary program for adult residents of DuPage County. If interested in learning more about any of the services provided by DuPage County Health Department at Crisis Services, please call 630-627-1700. I want to thank the Homeland Security Training Institute for allowing me the opportunity to cover some basics about common mental disorders and suicide prevention with all of you today. Hopefully, this information will allow you to feel more confident in supporting individuals experiencing mental health symptoms or during a crisis situation. Thank you.
Thank you, Betsy, for that important information. Sylvia Donatelli is a mental health counselor and faculty at College of DuPage. Sylvia is a licensed clinical psychologist in the state of Illinois and has earned her PhD in counseling psychology from Purdue University in West Lafayette. She has worked with diverse populations in various settings, including college counseling and community mental health centers. Sylvia works from interpersonal process theory and incorporates evidence-based interventions, including acceptance and commitment therapy principles. She also teaches career development classes at COD.
Thanks, Tom. What I'm going to cover today is a little bit about what mental health treatment or counseling is and what it's not. I'm going to talk about how you might encourage someone you're concerned about to seek treatment or counseling. And finally, I'll go over some ways you can access or help someone you care about access the help that they need. So what does mental health counseling look like? It's important to know a little bit about this for two reasons. One, we often get our ideas about counseling or mental health treatment from the media, TV shows. That's right in front of us. We see it all the time. And people tend not to talk about the treatment that they're getting because there's still a lot of stigma around it. So we're getting a lot of misinformation out there and not always the facts. Two, we are in a helping profession. And so even if you're not in a helping profession and just want to encourage a friend to seek treatment, it can be helpful for you to know the facts and the myths so that you're giving them appropriate information. So what does counseling look like? There's really no short answer to this because there are a lot of variables that will determine what it looks like. And counseling has also changed a great deal over the years. It's become a lot more flexible and has adapted because of technology and our changing environment. So I'm just going to give you an overview. First, we have different types of counseling. So individual counseling is probably what most people think of when they think of counseling. It's where the focus is really on you, and you and the counselor will work together to find new ways of coping with a problem. There's also couples counseling, which this is a little bit different because the focus is not on any one person, but instead it's on the couple as a unit. And the goal often involves helping the couple find new ways to relate to one another. Family counseling, again, the focus is not on any one person in the family. The focus is on the family as a unit, and the family is really the client here. So the goal is usually to help members of the family interact with each other, and the idea is that that will change the family as a system. Group counseling is usually led by a professional counselor and has several members, and usually anywhere up to 15 people. There are structured groups where there might be a certain amount of sessions, like 8 or 12 sessions. And there are also unstructured groups where maybe the focus is on a specific issue like substance abuse or depression. Groups can be helpful for several reasons. First, members of the group tend to hold each other accountable to goals that you might have for yourself. And they can also serve as a sounding board to give you specific ideas to solve a problem that you're going through. And finally, they really help people feel like they're not alone in what it is they're struggling with. There are also support groups, which are a little bit different in that they can be led by a peer, and they usually bring together people who have gone through or are going through a similar experience. They can be offered by nonprofit organizations, a clinic, a hospital, or even a community organization like your local church. Traditionally, they have been in person, but again, as I mentioned earlier, there are a lot of groups available online now, and I will go over how you might find some of those at the end of my presentation. So there are different levels of care for counseling depending on the severity of what a person is going through. If a higher level of care is needed, you might be thinking about hospitalization or inpatient care, and that can go all the way down to outpatient care. The length also varies. Typically, sessions would be 45 minutes to an hour, but again, that can depend as well. So groups might be longer, where they can be an hour and a half or 2 hours, whereas a check-in appointment can be 15 minutes or half an hour. The frequency, this varies as well. Usually, counselors will like to meet weekly or bi-weekly, especially in the beginning, just to help build a relationship and keep the momentum going. But that doesn't always have to be the case either. So counseling has really become more flexible to meet the needs of the person seeking the care. Modality of counseling, as I mentioned earlier, has also changed. So traditionally, it was usually in person, but now, especially with COVID, but even before COVID, counseling has started to transition to be to have online options as well. And again, I'll go over some of those options at the end here and when we talk about accessing care. The process of counseling tends to be similar, where the beginning, it will usually be where the counselor is trying to get to know you. So they'll go over things like your medical history, your mental health history, your family history. And the focus will be on what are your goals for counseling. Knowing your goals is really important because that's how you know it's working. So a good sign that your counselor is paying attention to that is that do they check in on, are we meeting your goals? Do you feel like we've made progress on that? And so having goals at the outset of counseling is a really good first step. The other thing that's important in the process is what's called an informed consent. And this is really a chance for you to understand your rights as a client and to know about what the boundaries are between you and your counselor. So this is usually done in the first session so that you know what you're getting into from the beginning. Overall, counselors are going to work collaboratively with you. Counseling is confidential and it's voluntary. So these are the most important things that kind of stick out when we think of why people don't want to go to counseling. And so now I'm going to transition to talk about how you might encourage someone to attend counseling, and you'll see these issues of confidentiality kind of come up as we talk about that. So when you're trying to encourage someone to seek counseling, there are a couple things that can be helpful. The first one is to consider your timing. So often we will tell someone they should get help when something has just happened. Maybe they just got a DUI and they've called you for help, or maybe you're in the middle of an argument. But when tensions are high and emotions are overwhelming, it's usually not the best time to mention counseling to someone because we are in a defensive state. So usually trying to find a time when nothing has really happened and things are relatively calm is the best time to bring up your concern for someone. The next tip is to be direct. So when it comes to things like mental health, we have a tendency to dance around the topic. We don't want to bring it up, or we're worried that we might offend someone. We'll speak in euphemisms. So in general, it's best to be direct and simple. In fact, being direct can actually help someone. And Betsy mentioned this when talking about suicide. This is a perfect example. When we feel comfortable to say the words and to put it on the table, we are letting the person know that we're a safe person to talk to. And we've removed some of that isolation and shame that the person might be feeling about it. Another tip is to use your observations rather than judgments. And this is easier said than done, but being specific about the behaviors that, that you see can be helpful. So you might say, so instead of saying something like, you seem depressed, you might say, you've missed 8 days of work this month, and I noticed you were crying when X. So you're showing them versus telling them. And then this avoids your making generalizations about them. It kind of helps someone to not feel as defensive because it's really about factual behaviors that you've seen. We also want to listen, be caring, and use empathy. It's important to show our care after we've talked about the facts or our observations. We don't want to lose sight of the fact that you care about this person on some level. If you didn't, you wouldn't be encouraging them to seek help. So depending on your relationship with the person, your level of care might look different. So you can start the conversation with facts and reasons why you're worried about them, and then simply stating that you're concerned or worried can go a long way. So you might say something like, I'm really worried about you, and it makes me sad that you're struggling with this. So that normalizes, then you want to normalize the need to ask for help as much as possible. So letting them know that it's okay to be struggling with something like this, or a situation like this would be difficult for anybody. So that kind of is what you would do to show empathy and that you care about the person. You also want to know your limits. It's not necessarily your job to become a person's therapist, and this can be a hard line for people to walk. Sometimes we don't want to bring something up because we're afraid that we don't have the expertise to handle whatever they might say. And so just reminding yourself that you don't have to be the one to be their therapist or to handle it, but just showing you care, being there, being willing to listen is really enough. And then you can pass the baton to a professional. And so we'll get to that in a little bit here. So just knowing that you don't have to be their therapist, and whenever you do start to feel uncomfortable, that reminding yourself that your role is really to pass that baton. And then you want to provide the referral. You want to suggest that counseling could be helpful for this person. So saying something like, it sounds like you're telling me that this problem is very complicated and I want to help, but I think it might be more useful to talk to a professional. So just letting them know that you care, you want to help, but that a professional might be able to help more thoroughly. You also want to realize that your offer to help might be rejected. And this is really hard for people because sometimes it might prevent you from providing the referral in the first place. If you think, oh, they're not gonna want to go, or they're not gonna, I can't control what they do. And I hear this all the time from concerned parents saying, well, I really can't force them to go to counseling. And that's true. You can't force someone to go to counseling. So kind of trying to take some of that pressure off. All you can do is encourage them. And sometimes people in varying levels of distress are not really ready to take that step into counseling. So reminding yourself of that you don't need to force them. The end result might be that they don't go. But if you've taken that step to encourage them and start that conversation, that can be a small step forward. You also want to give them an opportunity to consider some alternatives. And so maybe we might think that our end goal is for them to go to counseling, but maybe they're not there yet. And so you might want to lower the bar, so to speak, and maybe say, I'm not saying that you need to commit yourself to counseling, but maybe just go to a first session, or maybe just make the phone call. Offering to go with them or drive them to an appointment can be a way to offer some more support. And finally, knowing a little bit about counseling and the myths can go a long way. As I mentioned earlier, there's a lot of misinformation out there. And so if you are armed with the facts, that can really help tackle some of those issues. So next, I'm going to talk about what the most common myths about mental health treatment or counseling are. Stigma. This is huge. So often people will say things like, only crazy people go to counseling, and I'm not a crazy person. So we have come a long way as a society in terms of how we view counseling, and there's a lot of reasons for this. But there still continues to be stigma. And even if as a society we've come a long way, depending on that person's individual family or community, there still might be more stigma for them. So one way to get around the stigma issue or to address it is just to let the person know sometimes that you don't think they're crazy goes a long way. And then reminding them that people seek counseling for a lot of reasons, including things like, feeling hopeless or relationship concerns, or even just self-improvement. And so there doesn't have to be something wrong to seek counseling. It's really just a way to make yourself a priority and work on improvement. Privacy is another huge concern. People think that the counselor is going to share information with other people. If you're a minor, you might be worried about what your parents might find out. At COD, as a counselor, we deal with this a lot because we're on a college campus. And so people think my teachers are going to find out what's going on with me. But in general, counseling is confidential. So there are some rare exceptions to that, but part of that informed consent process that I talked about earlier is that the counselor will go over in detail with you what privacy and confidentiality will look like. And so you should never be in a situation where the counselor is going to share information without your knowledge. Disclosure and feeling comfortable sharing information, especially sensitive mental health information, is another stigma around counseling. So people are worried that the counselor is going to force them to say stuff that they're just not ready to talk about. And this is not the case. I know we see this on TV a lot. This is one of those big ones that comes up in the media. Counseling is really your process, and a good counselor will allow you to take it at your own pace. And if you're not ready to talk about something, they're not going to force you. So there's also this concern about being weak. People will often say, if I go to counseling, it means I can't handle my own problems. And so a helpful response here can be to let people know that they're capable of handling most of their problems, but there are some that are just difficult to handle alone. And that recognizing when you need help and then getting it is a good sign of problem-solving ability. Effectiveness is also a concern for people. There's this idea that counseling won't help me. And what you can do here is just let people know that they're right. Counseling results are not guaranteed, but there is a high probability that counseling can be helpful. It's worked for a lot of people. And if it can be helpful here if it's worked for you to maybe share a story of how counseling worked for you, even if you don't want to go into the details of what brought you to counseling, just letting them know that it has worked for some people can be helpful. And so next I'm going to talk about how you can access support or find a therapist or counselor or mental health specialist. Okay, so if you finally decided that you're ready to begin counseling or the person you're talking with is ready, how do you go about finding a person or mental health treatment that can fit your needs? And this can be a very overwhelming process. So I'm going to give you some tips on how you can begin to explore your options. So the first is if you have health insurance, you can start by calling your insurance company. They will give you a list of providers that are within your network that you can reach out to. And so there are some good questions that you want to ask your insurance company when you call them. And so you want to start by asking which mental health providers your insurance policy covers. And so there are some policies that cover some types of counselors and not others. And so that's an important piece to consider. You also want to ask if there's a deductible for mental health or behavioral health. Some policies have amounts that you need to pay before the insurance will start covering the costs related to mental health. You also want to ask at what percentage your policy covers. Some policies may cover 100% of the costs, while others may only cover 50 or 80%. This can vary a great deal from policy to policy. You also can ask if it has a session limit. Some policies will limit the total number of dollars that they'll pay for a specific service in a given year. And finally, you can ask about privacy. This especially is important if you are on somebody else's policy. We have a lot of concerns from people that think just because they're on a parent's policy, for example, that that individual has the right to know any information related to your mental health treatment. And that's not always the case. Policies are structured differently. And so sometimes even if you don't have your own insurance, you're still guaranteed certain privacies. So back to ways that you can access care. Another option is for you to seek a referral from a medical professional. So your primary healthcare provider is a good place to start. They will often have agencies or practices or individuals whom they work with that they can refer you to, and they usually take into consideration your insurance network as well. You can also reach out to your county health department. For example, Betsy from DuPage County talked earlier. At COD, we rely on DuPage County a great deal for referring students. They manage resources for us, and they can provide referrals to students even if they can't provide the care for that student. You can also look through resources through your employer. So many companies have employee assistance programs, often called EAPs, which provide counseling or other support to employees. For example, COD has an EAP, which provides that support to employees of the college. So if you're working, you can ask your human resources department or benefits coordinator if an EAP is available. Often, they're free to the employee for a specific amount of sessions. You can also look at your school or college resources if you're a student. So usually K through 12 schools will have school counselors or social workers or school psychologists available to support students and their families. For mental health needs, schools would likely work with that family to refer to a community support. And colleges and universities have varying levels of support for students. Most universities will have counseling centers that are staffed by psychologists or counselors, and even community colleges have this type of support available. At COD, we have counselors, and I myself am a mental health counselor here. And so this service is often free, again, with often a session limit associated with it. And finally, you can use online treatment locators. For example, Psychology Today has one that you can filter your search by things like gender, faith, location. And SAMHSA also has an online treatment locator that's similar, that will provide you with information about local mental health services. So there are also some resources to help you find online support groups that I mentioned earlier. The Anxiety and Depression Association of America has an online support group. Mental Health America Support Group Central is a place that can help you find a support group online or in person. Open to Hope is one that's specific for grief, and Smart Recovery has online resources specific to addiction. Some other resources that can help you access care: NAMI Helpline has a website that's very helpful in terms of connecting you to resources or online support groups. And you can also call, where you would be directed to a peer support that will help connect you to resources in the community. And again, DuPage County Resource Information System is an online system that DuPage County runs that has information about community resources in the COD area. So that wraps up my portion of the presentation. I want to thank everyone for joining in and for the opportunity to present. If you have any questions about the material or about counseling at COD, please don't hesitate to reach out to me. I'm happy to talk with you more about any of the information I presented or to provide you with more specific resources available in the COD area.
Thank you for viewing this HSTI Community Workshop. We hope you found it informative and helpful. If you have further questions or need to reach out for additional help, visit the HSTI website at cod.edu/HSTI and click on Community Workshops on the right-hand side. Resource links and numbers will be listed. Please join us in our future community workshops. If you have topics that you would like us to cover, please email us at hsti@cod.edu. Thank you and stay safe.